Funding provided by Access Health CT.
The coronavirus pandemic has highlighted a fundamental fact. Disparities in health outcomes by race and ethnicity exist across the country and the state, and COVID 19 has taken an unequal toll on Black people, Latinos, and Native Americans. Nationwide, Black people have died at nearly 2 times the rate of white people, and in Connecticut, Black people make up just 10% of the population and 14% of COVID deaths, according to COVIDtracking.com. The economic impact of COVID 19 on communities of color has been equally staggering. In this episode of Cutline, we look at COVID in Connecticut through the lens of race and equity. We'll talk with stakeholders and care providers, and we'll examine the structural issues that force people of color to bear a disproportionate burden of the virus's wrath. I'm Kalila Brown Dean. This is Cutline. The loss of Morgan Cobbs Jr. and Evelyn Cobbs are just a few of the nearly 600,000 COVID-related deaths in this country, more than 8,000 here in Connecticut.
Both my dad and my grandmother were sort of slowing down just a bit leading up to them going to the hospital. My dad had had a cough and something that he had been battling for some time. It sort of went away, but then not really. And this was taking place in March at the time when things were just closing down. Things were quite scary. We were all, asked to be on lockdown. And, we were kind of pleading with him a little bit, Daddy, we think you should go and get a COVID test. Also, at a time when COVID tests were sort of not that simple to come by the way they are today. Yes, he was able to go to a drive-through and get a COVID test, but results were not, immediate. There would have been like 5 to 7 days for a result to find out. And it turned out with him, we didn't really have 5 to 7 days. What ended up happening was that cough was really getting the better of him. I could hear it, my sister could hear it. And, we decided, why don't we just call paramedics for you and get you checked out? I remember when the paramedics came that day, it was a chilly, cold, March, rainy day. And for all that we had been seeing on the news, it was just so striking to see EMS teams, really just literally put on all of their PPE gear outside in the rain before they would even come and, put their hands on my dad. And they took him. And we thought, at least he's in a good place. We certainly couldn't join him due to protocols around, pedestrians going into the hospital. But what happened was my grandmother, who he also cared for, began to show signs of weakness, just a day later. And someone who was a really good eater, she didn't want to eat. So I had been calling her physician, throughout the day. And in the end, what I was seeing, and unbeknownst to me, but what was exhibiting itself was symptoms of COVID for her. And so literally, if my dad went on Friday, we were calling the paramedics yet again for my grandmother on Saturday.
I do recognize that we didn't know a lot about COVID at the end of March. We didn't know what we know today. I'll say it that way. Um, but there are inequities that showed up pretty quickly. So an example was when we convinced him to get a COVID test, I gave him the number to call, and he called me back shortly after and said it was denied. And I said, "Well, Daddy, what did you tell them?" And I said, "You have to tell them that you've received a kidney, that you're a kidney transplant recipient." I said, "Tell them that," and I gave him some other things to say that I wish I didn't have to tell him to say on his behalf in order to get the test. And the test was still denied a second time. And so, I'm now scrambling thinking, who can I call within the health system to get my father a COVID test? And about an hour or two later, he called back and said someone had reviewed his medical record in Epic, and they were going to offer him a test because he was, considered at risk or compromised. But over that 2-day period of, the worry, the back and forth, trying to get him a test, I was there to advocate for him. But I think often of how many people didn't have a daughter who works for the hospital where their father is trying to get their test from.
Dana Cobbs, Darcy Cobbs Lomax, thank you so much. To give context around these inequities in the healthcare system, I'm joined by Dr. Takesha Everett, Executive Director of Health Equity Solutions, and Darcy Cobbs Lomax is still with us. She's Director of Community Connections and Social Impact for Yale New Haven Health System. Takesha, we've heard a lot about the notion of equity over this last year, but what exactly do we mean when we say health equity?
Well, when we're talking about health equity, we're thinking about the fact that at the origins of our country, not everyone was treated equally or had equal access to health and health care. When we look at that in the contemporary sense, we're now seeing the outcomes of poor health status or worse health status. People living in neighborhoods that don't necessarily provide the community resources or health resources that are necessary to attain great health, their best health. So ultimately, when we're talking about health equity, we're looking for everybody to have a fair and just opportunity to have their best health, regardless of any social factors. So without regard to race, ethnicity, geography, income, education, etc.
Darcy, how do these health inequities show up when we're talking about both access to health care, but also the quality of that care? Where are those disparities and who's most impacted?
So that's a great question. At Yale New Haven Health, and I would venture to say many health systems across the state and the country, we follow the same definition that Takesha gave of everyone having a fair and just opportunity to be as healthy as possible, as how we're defining health equity. And as she mentioned, it requires us to be intentional about naming racism and poverty and other social constructs as undercurrents that produce inequities in our community. So within health systems, whether it's in the hospital or an ambulatory care site, we see health inequities show up in a variety of ways, including high readmission rates, longer length of stay, poorer health outcomes, or disparities, if you will, between one population and another. And health systems have struggled with this for many years with how to manage these inequities. They show up in quality. They show up in the responses that we get from our patients. Um, so there's a lot of initiatives that are happening within Yale New Haven Health System and across the United States. But this is not a new challenge for us, but certainly COVID has, if you will, ripped the Band-Aid off and exposed it more broadly outside of our health systems and healthcare centers to the broader community.
Takesha, let's talk about that because Darcy said this is not new to people who work in the field or to people who experience these kinds of challenges. But for most people, it took this global pandemic to bring this type of attention. What is it that we have learned over this last year, and what should we be doing differently?
Well, I like to think of it like this. There are many of us who knew before the pandemic the vast inequality and inequity that existed in health. But if we didn't know before, we definitely know now. We've been forced into our homes and not only able to read and see on television and through all of the data and statistics that have been shared, the deep, disproportionate impact COVID-19 has had on communities of color and people of color. But paired with that, we've been seeing the news about the police brutality and the community brutality against people simply because of their race and ethnicity. I would dare say what we've learned is that we can no longer ignore the deep inequities that exist in our country, that we are called to do something about it. And what I'm hopeful for is that we're going to move into action on these things, which I think we're starting to see when you're looking at people who are examining deeper now, asking the question, why did the pandemic hit communities of color and people of color in such a disproportionate way? And what are we going to do systemically to attend to that? Those are the questions I think that we are dealing with now as a society.
Darcy, there are lots of questions that we're contending with. There are interventions that are happening. What are you seeing in terms of where we go from here and those positive kinds of steps that we can take to address health inequities?
Sure. So, Takesha's aware of this fact, and you may be as well, that we're often told in healthcare that it's only 20% of what happens in the doctor's office that affects your health outcome, that it's really 80% of what happens outside of the hospital walls or the provider's walls that will affect your health outcome. So internally, when you're at a doctor's appointment, the doctor is there to provide care. However, if the patient that's in front of you has limited English proficiency, if there's not the appropriate interpreter services available for a patient, and that includes sign language, if the patient doesn't feel comfortable or confident, oftentimes patients leave and don't have all the information that they actually need. So they get home and they deal with all of the social determinants of health that we hear talked about widely now, such as issues of food insecurity, housing concerns. If you have asthma and you live in a place that has environmental hazards or concerns, and so there's lots and lots of other things that happen outside of the hospital walls in the community that affect someone's health outcome. If you don't have transportation to get to your next medical appointment or follow-up, that can also be problematic. Internally, what we're seeing within our health system, and I think others across the country, is a real focused effort on equity, beginning first internally. So equity with our own employees, who are also our community members, who are also our patients. What do our policies say, and how fair and equitable are they for the frontline worker to our CEO? And we're also spending a really focused amount of time on our collection of race, ethnicity, and language data, which has not always been a focus for us within the health system, but it is today. And that's really, really important for measuring outcomes, for measuring disparities. Outside of the health system, it takes a whole community to improve health outcomes. And I've lived in 4 different states, and Connecticut is the first state that doesn't have county government systems. And that's I think I think it makes it difficult sometimes to work on initiatives when your health department covers one city or one town or a smaller health district. So I think that is a bit of a limiting factor for us here in Connecticut.
There's definitely more work to be done. Darcy Cobbs Lomax, Dr. Takesha Everett, thank you for joining us. Black and Latino residents are less likely to have health insurance compared to the total population. Employment and income often determine whether people have access to health insurance. But for undocumented immigrants, citizenship status creates additional barriers to accessing preventative health care. Connecticut Public Radio's Brenda Leon reports on what it's like to battle cancer while undocumented during a pandemic, and the role that community health centers fill for underinsured communities.
Patricia Rosas has survived both the coronavirus and cancer, but now she worries about paying for a screening to confirm her remaining kidney is cancer-free.
Pensaba ya porque han pasado ya 5 meses y estoy empezando a preocuparme porque no sé cómo estoy. O sea, no me siento como que estoy mal, pero igual tenía el cáncer y no lo sentía, así que tengo un poco de temor, ¿no?
Rosas is from Mexico, and she's 52. She's among the 120,000 undocumented people in Connecticut who aren't eligible for state health insurance for people with low incomes. That's because they need to have citizenship status in order to qualify. About 6% of the state's population is uninsured. According to a study by Access Health Connecticut, Black and Latino people accounted for 19% of the uninsured population in 2018. But that's only counting people who are citizens. Meanwhile, 52% of undocumented residents are without health insurance. That's according to the Migration Policy Institute. Rosa says she suffered in pain and silence for years, fearful that she'd be turned away from proper care due to her immigration status.
Me daba un dolor en esta parte derecha, debajo de la costilla, que me dejaba sin aire, era un dolor que molesta mucho. Y curiosamente me he dado cuenta que mucha gente lo ha padecido y ya no puedes estar ¿cómo se dice? Tranquila, por ese dolor no te deja tranquila. Así que por eso decidí, ir y buscar atención médica, pero la doctora solo me dijo eso, que ella creía que era una piedra en la vesícula, que no me podían atender ahí porque no tenían el equipo.
Rosas was sent home. That was in the spring of 2019. With a stone in her gallbladder, Rosa says she delayed her visits to the emergency room. Finally, in the summer of 2019, Rosas was able to be screened at a low-income community health clinic, even though she didn't have health insurance. She then got a referral to a specialist, but as the pain got worse, she didn't make an appointment, still afraid she wouldn't be able to afford it.
Yo dije, bueno, me enviaron a una especialista, pero yo no puedo ir a una especialista porque yo no tengo dinero para pagar eso y no tengo seguro, así que no me van a atender. Y pasaron días hasta que una amiga me dijo, yo te pago para que vayas con la especialista y sepas qué es lo que tienes, es urgente, es necesario que lo hagas.
Across the state, community health centers provide primary medical, dental, and behavioral health care, regardless of a person's ability to pay. In Hartford, the Hispanic Health Council serves families under a model that bridges access to clinical services, preventative health education, and family wellness. The organization was founded in 1978 after the tragic death of a baby girl whose Spanish-speaking mother couldn't understand the medical instructions she was being given in English. This tragic death moved leaders to push for advocacy and health equity. Yesenia Conde leads the council's youth services department. On average, the council serves over 200 families a year. With the coronavirus, that number nearly doubled. Conde says it was eye-opening.
The pandemic allowed us to not just serve the families in-house, but it allowed us to see that the need is even greater than what we thought. Basic needs, mental health, social and emotional development in the children. We serve a lot of immigrant families, Puerto Rican families. We serve Mexican families, really all Latino families. We serve African American families.
Conde says about 20% of families get services in more than one of the Health Council's departments.
So that family will be receiving risk assessments, they'll be receiving home visitation, they'll be receiving referrals to other community agencies, they'll be receiving one-to-one services, and we do follow-up. When and if the parent already received the service that they have requested that they want, we always make sure that we follow up every month, once a month. And even when the case is closed out, we still keep them in our system for about 6 months just to make sure that they're adjusting and that they don't need to come back.
The Hispanic Health Council also trains their staff in cultural awareness, not only to understand the different cultures of the community that they serve, but how their health intersects with other needs.
Is it job placement? Is it mental awareness? Is it health equity? So a lot of our families that are immigrants unfortunately don't have health insurance, but their children do. So then, or a lot of families are scared to go to the doctor's office because they don't have health insurance or because they feel like they're doing something wrong.
Arelis Insignares works as a community health worker, promoting family wellness, working directly to educate families and connect them with services. While the pandemic interrupted home visits, the center remained open. But more recently, Insignares resumed in-person visits with mothers and their children as part of their family resource center. She works with mothers like Gladys Escalante, who arrived from Guatemala 15 years ago. Escalante has been working with Insignares since the birth of her first daughter 10 years ago. Like many of the families who visit the Hispanic Health Council, Escalante's family is of mixed citizenship status. While Insignares is able to direct Escalante in the right direction to access health services for her daughters, the help that Escalante can get herself is limited.
Porque solamente mis hijas tienen un seguro médico y, por ejemplo, yo no. No puedo ir a un doctor así o como porque no tengo cómo pagarle. Es como ahorita tengo los dientes muy malos y no tengo cómo ir al doctor porque hay que pagarlo. Sí.
¿Y tú en estos tiempos, pero has podido estar al tanto con la salud de tus hijos?
Sí, también soy diabética. Soy diabética con esto. Sí. Y a veces no tengo cómo pagar las medicinas, porque tampoco trabajo.
So she works closely with Insigniatis to educate herself and control her diabetes.
Probablemente algo que pudo haberse evitado se convierte en algo mayor porque no tenían acceso o tenían miedo de decirlo. Entonces llegan a donde nosotros y como el Concilio Hispano tiene una variedad de programas, podemos trabajar en conjunto y tratar de ayudar lo más que se pueda a esa familia, pero algunas veces llegan tarde.
During the pandemic, Arelis Ortiz Perez worked packing tomatoes up into her last months of pregnancy. She's also a participant in the family wellness group.
La canción dice, no, ya no vamos a cuidar los niños, y no podemos trabajar, a veces uno pierde su trabajo por cuidar a sus niños.
Together, the women learn about key resources while Insigniatis helps to facilitate workshops that become a key component of learning to prevent health crises.
Por ejemplo, una persona que tuvo problemas con su presión, ni siquiera se chequeaba su presión porque no iba al médico. Entonces, cuando se da cuenta es porque uno de los programas que tenemos se toma la presión y la tenía altísima. Y de ahí pues se le refirió, se le buscó y se pudo evitar, sí. Dentro de lo que le proveemos, trabajamos mucho con la prevención. So, no esperar a que llegue a eso, pero es difícil cuando no tienes el acceso a los servicios gratuitos, muchas veces son limitados.
Ella vino conmigo ese día y cuando la doctora llegó al cuarto, sin más ni más me dijo que tenía cáncer en el riñón. Yo ya no dije nada, no pude hablar, estaba como que paralizada.
Rosas was admitted into surgery in November of 2019, nearly 7 months from her initial visit to her local community health center. Prior to her surgery, friends and family started a GoFundMe to help her cover costs. She was able to get financial help from St. Francis Hospital. Her final bill of $57,000 would have left her in crippling debt.
Por ejemplo, ahorita en diciembre a mí me tenían que revisar porque la doctora que removió el riñón y la que removió la vesícula me tienen que revisar por 5 años cada año para que estemos seguros que el cáncer no está otra vez o que regresó o algo así. Entonces, por no tener seguro médico, no he podido ir. Han pasado 5 meses y no he podido ir. Entonces eso he tratado de que no me afecte, pero sí de repente empiezo a pensar, ¿y si otra vez tengo cáncer? ¿Y qué va a pasar por no tener seguro médico? De ahí fue que empecé a compartir mi historia en la legislatura.
In the past year, Rosas has participated in numerous rallies and shared her testimony.
Mientras no se haga algo con ese problema, entonces mucha gente va a seguir muriendo y teniendo problemas de salud que a la larga los van a llevar a eso, a morirse.
Joining me now in studio is Connecticut public reporter Brenda Leon. Brenda, talk to us about what you're seeing in the various communities with regard to health inequities.
Well, Clyda, I'm seeing a lot of things. The first thing that comes to mind is the access to the vaccine, right? And we see that Latinos have the lowest vaccination rates throughout the state, and there are a couple of reasons to that. People have talked about hesitancy, but there's also the component of education, right? And really gaining the trust of the community that they're trying to serve. And so that comes in a couple of ways, right? Really gaining trust with the community, especially in regards to serving them in a way that's culturally understanding of who they are and what needs they have, right? But aside from that, there's also a lot of a need for more resources for things like nutrition, right? And things like regular preventative healthcare services. And so that also ties into the experiences of families who might not be well acquainted with the American healthcare system, right? And because the Latino community is very diverse in and of itself, we're not talking about a monolithic group, right? We're talking about people with many different experiences and many different circumstances, right? Economically, with regards to citizenship, and also with regards to income. And so that plays a role in how I'm seeing how health equity plays a part in the experiences of this community.
There's so many layers and so
many
many
layers.
dynamics at play that shape these health outcomes. And one of the layers that you mentioned was nutrition and access to food. And you spoke with a woman who was running a food pantry out of her home in Hartford. Talk to us about that.
Yes, Xiaomi de la Cruz is a young mother who came from Peru. And because of her own need, she started going to food pantries and collecting things. She had a surplus of things, and she started a food pantry in her living room because she saw that other mothers were also in need. And so that became, and it happens a lot within the Latino community. I've been learning that people find out and the information goes out word of mouth. And so people are looking for, essentials, right? Not only food, but also diapers, milk. And Xiaomi de la Cruz built her own pantry, and essentially that became a bigger project, and it was called La Bodeguita de la Gente in Hartford. And it was serving over 200 families in Hartford. And so she was very aware that the heart of the Latino community was in Frog Hollow. And so they created a store where not only that they have the pantry, but also clothing and different items that families might need on a day-to-day basis. So these little things that we take for granted sometimes are sometimes very much needed for families who can't afford to have additional expenses throughout the week.
One of the challenges that you've reported on is for people who may have limited English proficiency. They may have a difficult time accessing care for themselves and for their family members. Talk to us about that challenge.
So Milagros Vega needed support with her grandson's schizophrenia. And she didn't have anywhere else to call in a moment of crisis except to call the police. And so there was a language barrier, right? And so when I spoke to her, she expressed, this is not only with the police department when we are in need of a preventative, right, or a prevention rather, in a moment of crisis, because I need to be able to communicate with someone who understands my language. And throughout that, it's not only with the police department, but also in the healthcare system as well, right? Where families who might feel like they won't be attended properly because they don't know how to fluently speak the language, right? And as I've learned throughout my reporting, people who tend to go and seek healthcare services and go with someone who's an ally and can speak the language, there's a better outcome than someone who goes and tries to navigate the system by themselves.
As you said, there's so many things that we take for granted when it comes to healthcare access and the kinds of outcomes that we see. Brenda, thank you so much for joining us.
Thank you.
People of color experience tremendous disparities in health outcomes across a range of factors that's largely rooted in patterns of systemic racism that shape healthcare delivery and other areas like housing, education, economic opportunity, and environmental impact. Joining us now to talk about access to care and possible solutions are Kika Matos, Vice President of Initiatives at the Vera Institute of Justice. Dr. Satu Vora is Chief Medical Officer for the Mashantucket Pequot Tribal Nation. Stephen Hernandez is Executive Director at the Commission on Women, Children, Seniors, Equity, and Opportunity. And Reverend Robin Anderson is pastor of the Blackwell Memorial AME Zion Church and Executive Director of the Ministerial Health Fellowship Advocacy Coalition. Kika, the pandemic has highlighted a legacy of health inequities that exist in our state. Talk to us about what you've been seeing and what's top of mind.
Yeah, so I live in a neighborhood in New Haven, Connecticut called Fairhaven. Fairhaven is a community whose population is 83% people of color. It is densely populated neighborhood. It is where the majority of undocumented immigrants live in New Haven, and it is a place where a significant number of essential workers live. And when the pandemic hit, it really exposed the fault lines that we see in this state when it comes to issues of race and access to healthcare, and issues of equity. And so the bottom line when it came to the pandemic is that we had one of the highest rates of infection in the entire state. And then when the vaccine began to be rolled out, we were one of the communities that had least access to the vaccine. Because we have a significant number of undocumented immigrants, we also saw the lack of attention and access to solutions around the pandemic and equity when it came to some of the most disenfranchised people in this state.
So what would more attention look like, but also the appropriate attention to improve some of the challenges you just mentioned?
I have said very bluntly that the state has failed communities of color in this state, in New Haven, in my community. Why is that? Because people of color are routinely marginalized and left behind. Despite the fact that the pandemic hit my community, the infection rates were 3 or 4 times that of other parts of the state. At no point in time did the state focus attention on communities like mine to say, okay, we have a significant problem here. We have to identify the reasons why the pandemic is affecting this community of color uniquely, and we have to figure out what we can do. So we were left on our own devices to try to figure out how do we get access to the PPE to give to communities of color? How do we try to protect our communities from this devastating illness? How do we support people who have loved ones die and they can't afford the kind of burial that they want to give them? When it came to the pandemic, what did we see? We again saw a real lack of attention to issues related to culture. So for example, a lot of the website that provided pandemic information was in English only. You could hit a button to have a terrible Spanish translation. A lot of the fact sheets were also in English. We're looking at a population in my community with lack of access to Wi-Fi, a lack of access to computers, significant language barriers. And we realized in short order that we were going to be the ones who were going to have to find the solutions to these problems ourselves. And that's what we set about to do.
So Dr. Vora, Kika mentioned a number of those systemic challenges. And I wondered if you could talk to us about how poor access to care and engagement in the communities that you care for are playing out.
Certainly, I represent the health interests of the Mashantucket Pequot Tribal Nation as its Chief Medical Officer. But I can speak certainly from my experience from learning throughout Indian country that access to not just the care, but timely, trusted information delivered by local champions is oftentimes missing in Native communities. And what the pandemic has highlighted for us is that sometimes just access is not enough. It has to lead to acceptance by the people that we all serve. And I think the central missing piece, perhaps, is the fact that trust is a vital determinant of health. And how may we start rebuilding, and in many cases, building trust, not during a crisis, but as one of my mentors in a mindfulness training told me, the best time to fix the holes in the parachute are when we are safely on the ground and not while we are actually jumping out of the airplane. The same holds true for our collective work with Native populations, Indigenous people, and certainly any other communities of color, underrepresented communities. So I think we have a lot of work ahead of us. We know that poor access leads to adverse outcomes. Native communities have much higher incidence of COVID They have a higher risk of comorbid condition that results in more severe disease and death.
Reverend Anderson, what about you? How are you seeing poor access to care and engagement in the communities you care for manifest?
Thank you for that question. In many different ways, the medical system really has in many ways, failed the Black and Brown community in terms of not really having access to care, whether or not having insurance. I've had several of my members of my congregation who were working with minimum wage jobs and were accessing insurance because they did not meet the income level for free insurance through Husky. And they were paying premiums, but had to make choices of whether or not to eat or to actually pay their insurance premium. So there's many people that have had that kind of experience. People in the medical field don't look like them. And so in many ways, they don't feel like they understand some of the concerns and some of the issues that they have had. I mean, we've been through this 100 years ago with the Spanish flu, the same thing. The disproportionate amount of people, because of health disparities, because of the lack of access to health care, people of color died in disproportionate rates, just like we're seeing now. And so the question becomes to me, what are we going to do so that people feel like they have access to health care and access that health care and also feel like people do have a genuine concern about their health care, and not just because we're in a pandemic and all of a sudden we need you for herd immunity. And so we want to make sure we're concerned about your health care, but really making sure that things are in place to address the disparities that Black and Brown people face each and every day.
Stephen, Reverend Anderson laid out for us a number of issues and challenges that seem nested, but they also seem nested across a number of groups. What are you seeing in the work that you do about how these issues show up?
Dr. Brown-Dean, thank you so much, firstly, for having us and for that question. You know, the deleterious social determinants of health, the way that we've talked about the social determinants of health for so long, in some ways avoids the vital point. And the vital point really came to a head in the state of Connecticut legislature, where Senate Bill 1, in Section 1, declared racism a public health crisis in the state of Connecticut. And what's powerful about that is that we have finally been able to utter as an institution that racism was by design deleterious to the health of people of color, specifically Black people in the state of Connecticut and in this country. So when we think about what it is that we see across the board, we don't only see these impacts in communities, African-American communities, but also in Latino communities and other emerging communities in the state. And why is that? Because the very infrastructures that were created to exclude some now exclude others as well. And those outcomes that we're describing, whether they be health outcomes, educational outcomes, access outcomes, intergenerational cycles of poverty, those are all the results. And because these systems were created to do what they did, they need to be reimagined and recreated to do something different. And that is the work of policy. That is the work of prioritizing budget. That is the work of working with impacted communities and hearing from their lived experience the barriers that they face every single day. I'll give you a couple of examples of what we're seeing, Doctor. First of all, let me give you the example of two gentlemen. These were two hypothetical gentlemen that were created by a study done by Access Health Connecticut, our insurance exchange here in the state, on health inequities. One gentleman born in the city of Hartford, the other one born just down the way, about 5 miles in West Hartford. Two very similar early experiences. They were each born into a family, but very different outcomes. An average of 15-year difference in life expectancy between the African-American gentleman and the Caucasian gentleman down the street. A quality of life that is severely diminished for the African-American gentleman, even though he didn't have the benefit of living as long as his counterpart 5 miles away. What that says to me is that at stops along the way, the infrastructures of support, of prevention, of intervention at the right moment, of continuous assessment and improvement when it comes to health were just not there for the gentleman in Hartford. So the real question from a policy perspective that we have to ask ourselves isn't how do we support the fact that we need to do something different? It's how do we actually do different to do better?
I want to talk about the impact, but also what is being done from the community level to address many of those structural factors that you just mentioned, Stephen, but to also push back against some of the challenges that Kika mentioned. And so, Reverend Anderson, talk to us about what you're seeing in the community in terms of the impact, but also efforts to address some of them.
One of the things that we have continued to see in having the COVID-19 crisis counselors who have worked all over the state is just to see people, one, that still did not have insurance, who really did not know where to get tested, did not really quite understand, about COVID-19 and the urgency and the frequency of being tested. And then to see also the amount of people that had COVID, and also the whole entire family had COVID-19, and not knowing where to quarantine, did not have a place to quarantine, did not have the funds to be able to quarantine as well. So one of the things that we have really done is to really, one, we made up wellness kits. We made sure people had masks. Many people that didn't have supplies made sure they had sanitizer. Made sure that they understood and knew about COVID-19, how to store their masks, how to protect themselves, the resources that were available to them if someone in the family received COVID-19, the contact tracing, and then also even when the vaccines came out, really educating them about the vaccine, where they can get tested, answering some of their questions, and sometimes even bringing them to get tested and also bringing them to actually get vaccinated. And so we have continued to see the real despair that has really continued to take place in so many lives and in the lives of Black and Brown people. So the question becomes, even as we speak about this and even as we talk about this now, what are we going to do to make sure we don't go through this again, that we're not back where we started from 100 years ago? With maybe a different pandemic with a different name, but the same disparities, the same racism issues that we continue to see, the same lack of access to health care, that it would be a tragedy that if we move through this pandemic, we still have the same issues going on and not a plan to be able to address those.
Kika, let's talk about that change that is happening, because as Reverend Anderson suggested, it's not about waiting for others to make those change. It's really often about communities organizing for themselves on behalf of their interests. Talk to us about how communities of color are mobilizing to address these inequities, both in access and quality of care, particularly in response to COVID.
Sure. So I would mention two distinct efforts that are taking place in Connecticut right now. At the state level, there have been significant organizing efforts taking place to push a bill that would expand access to the Husky Health Plan for the undocumented community in Connecticut. There's about 121,000 people who live in our state who don't have documentation. And 52% of these folks don't have health care, and this is compared to 6% of the population in the entire state. So activists are pushing to make sure that a bill passes to expand eligibility for this particularly vulnerable population. When it comes to the pandemic, I want to start off by quoting my friend and colleague, State Representative Robin Porter, who often says that those who are closest to the problems are those who are closest to the solution. When we came to realize that around COVID, our community was being left behind in terms of access to the vaccine, we decided that we were going to roll up our sleeves and get to work. And so we launched what we call the Vaccinate Vacunate Fairhaven campaign. And what we did was that we took the Get Out the Vote model and we offered people vaccine appointments. For those who were homebound, we offered to have healthcare professionals administer vaccines in their home. For people who needed rides, we offered them free taxi rides to the vaccination site and back. And we committed to knock on every single door in our community. And during the time period that we had this campaign active, nearly 5,000 people were vaccinated as a result of these efforts. And the local community healthcare clinic talks about the impact of our efforts to the extent that now 19,000 people have been vaccinated in their clinic.
Dr. Vora, that fight for equity and that fight for self-determination has been a persistent factor for tribal nations across this country, but particularly here in Connecticut. How are tribal nations organizing to demand health sovereignty and also change some of the outcomes that we've seen during this pandemic?
It begins with just being counted and recognized at the outset. And as most of you and the viewers know, Native populations are not unfamiliar with infectious diseases and outbreaks. If you recall with the Columbian Exchange, by some estimates, 80 to 90% of Native American populations at that time was decimated, right? So I think that's historical trauma is still alive and present, and ongoing contemporary trauma, systemic racism that our August panel highlighted already, results in a deep mistrust with the institutions and systems that exist, even when the encounters were non-healthcare related for many folks. So at Mashantucket Pequot Tribal Nation, we're fortunate that the Tribal Council and our respected tribal elders have always placed health as our number one objective. And the model of health sovereignty is always a work in progress. And what we decided was to certainly, build on that and secure access to vaccines through our partnership with local health districts and the state. The tribes were given two options: either work directly with Indian Health Service and the CDC, or work with local health partners. And we believe in local partnerships, and we had an ongoing engagement with our local community partners, healthcare systems, the state, and the tribe and its enterprises, both in terms of testing and tracing. And we took that model to the next level when it came to vaccination. And thanks to the leadership of the tribal elders, they set the tone and the example of being early adopters. And because of that, we were able to launch vaccination throughout Mashantucket Pequot Tribal Nation with safety and speed, and balancing equity with efficiency, so that not a single dose goes wasted and more shots get delivered and not on the shelf. So it truly has been a work in progress. There were a lot of lessons learned, and it comes down to the simple fact that it starts with total empathy. How may we collectively understand people and their concerns? How do we relay scientific information in a very transparent, easy to understand manner? And then finally, how do we create that network of teams that really act synergistically? We cannot do it alone. And if nothing else has been shown by this pandemic, it truly takes a broad public-private partnership to deliver on the value proposition for the people that we serve.
Stephen, it sounds like it's not enough to just talk about access, but it's also important to talk about people having options, good quality options, to make those kinds of decisions for themselves and for their communities. What are the solution-based demands that you are hearing from communities about being able to have those quality options and choices?
Well, thank you so much for asking that. So much of that, the informed choice, as we call it, comes from information and earnestly shared true information. And that is based and founded on an information infrastructure that is already there and trust that has been built. And what we found in the beginning of this pandemic, and even as we tried to work our way through those initial months, is that the reason that we couldn't find communities of color is because of that lack of trust. We had never built that critical part of the infrastructure of emergency response with our linguistically diverse communities and with our Black and Brown communities more generally. So part of what we were doing throughout pandemic is building it as we flew it. I'll give you an example. Some of our approaches were initially neutral. They were based on age, or they were based on more generalized ways of reaching community. That's not enough. It is community that will guide you into the front door so that you can have that direct impact. And so when you talk about choice, when you talk about options, health options, and informed choice, parents, families, communities need to know what the full landscape of their choices are in terms of addressing health. And that has to be honest. And where that landscape is lacking, where there may be an access desert, whether it be in medication, whether it be in information or prevention, we need to nourish those deserts back to life. And that is a relationship that has to be ongoing with the institutions that are here to serve the people and have not historically.
Dr. Vora, you said that one of the real strengths of the tribal nations in terms of the response here and action was that tribal leaders led by example in terms of embracing access to vaccines, but also promoting that as a solution. Do you think we would have seen better outcomes if tribal leadership and tribal nation had been empowered to do that earlier in the process of promoting vaccines?
I believe so. And we see that not just at Mashantucket Pequot Tribal Nation, but across Indian country. The Navajo Nation, as you recall, was one of the hardest hit. And that's the largest nation by geography and population as well. They had significant mortality, but they turned the tide because they embraced leadership and certainly led by example by participating in even phase 3 studies. And if you recall, Native communities are mistrusting because of real concerns around experimentation, forced sterilization, all the trauma that this group certainly knows about. So for the Native leadership to then embrace participatory research so that Native communities are represented in the study population so that the results are meaningful back to those people, that was a great leap forward. And I believe that Indian country has shown that when the local leaders take charge and lead, when they embrace health sovereignty and use science with common sense, the adoption is much better as compared to externally imposed or forced method.
Reverend Anderson, what about you? Do you agree that empowering communities of color to be able to lead some of that at the beginning may have helped us see more people getting vaccinated early on?
I believe that we would have been a lot further along had we done this at the beginning, had we brought faith leaders, had we brought community leaders, had we brought tribal nations, together and really discussed together. How are we going to do this? How are we going to reach the community? What are some of the things that you feel and you know that have worked? Because who knows our community better than we do? Nobody. It requires community people, trusted people who look like them, people that they know are not just for them, not just for here for them now, but have been there for them in the long haul. And when this is all over, we'll still be there for them.
Stephen, one of the most important resources necessary to protecting communities and advancing is trust. And it seems abundantly clear from this conversation that that trust is broken if it ever existed. And it's not just trust in community or trust in government and leadership, but trust that people feel their issues are being raised. How do we start to build or repair that trust?
Well, oftentimes we look at outcomes and we think that they are indicators of an ongoing condition. that is based in community. There's something wrong with community. When we see sickness, when we see poverty, when we see lack of access, our inclination is to think that something's wrong with the community. Well, in fact, it is the failures of the resources of government, of local institutions to really hone in on those problems, to hone in on those outcomes that are based by much larger and much deeper issues, to hone in on them with resources. It is that failure that we really need to address. And that is an element, there's an element of trust building that needs to go along with that. How do you do that? You do that by not overpromising. You do it by delivering on what you promise. And you do it by being humble before the task, being humble before community, and engaging community, as others have said, every step of the way. We don't need you to solve our problems. In many ways, we need you to stop being the problem that has exacerbated the conditions that we face in our cities and in our towns where Black and brown people live. The real fact here is that engagement, trust building, those are action verbs. And they are action verbs that need to be led by people with power, by people with resources, for people who have been downtrodden by those institutions generation after generation.
Stephen has given us a really important framework for thinking about what should happen next, so that we're not just addressing COVID-19 today, but also thinking about the lessons and action steps to be taken moving forward. Thank you all for joining us.
Funding provided by Access Health CT.